Good morning, everyone. It's always a pleasure to be back at HIV-NAT, Bangkok Symposium, and this time we've got, I think, a big team of Malaysians here to learn and from the conference. Continuing on this morning's theme of populations, countries, and individuals being left behind, I've been asked to speak on people who use drugs and the health needs of people who use drugs. And just in the artwork at the bottom of my slide there, just to remind that drug use has been with us since mankind, and so it really is nothing new, but it's in how we manage this problem that I think has created more harm than good globally. So in terms of the health needs, I think it goes without saying that there's increased prevalence and frequency of both medical and psychiatric illnesses in people who use drugs. People who use drugs die a lot younger than those who don't. And the number and range of comorbid disorders, not just substance use disorders, related complications, but other complications, in particular mental illness, is very much more prevalent amongst people who use drugs. And needless to say, this complicates care towards individuals who use drugs. So this is, let's start with HIV and Hep C. The HIV epidemic has been mentioned this morning. And as Fritz pointed out, nowhere in the world, except for perhaps Central Asia and former Soviet Union, where the incidence of HIV is rising a lot faster than the rest of the world. And in Asia, as you saw from the data that Fritz presented amongst MSM, that is contributing significantly to the lack of control of the HIV epidemic globally. Indeed, with people who use drugs, the situation is similar, if not worse, and you can see the prevalence rates in the I can't show. Anyway, the figures on my right are for HIV, and the figures on the left are for hepatitis C. And the numbers in Asia are essentially in the double digits in most of the countries in South and Southeast Asia. The prevalence is much more significant with hepatitis C than HIV. The background, the global map, is that of harm reduction programs globally, from the global state of harm reduction that the International Harm Reduction Association publishes each year. The red denotes presence of both needle syringe and opiate substitution therapy. And the blue is where neither opiate substitution therapy nor needle syringe programs are present. And of course, I think most people in the room would know that the Philippines are having huge problems in terms of introducing evidence-based HIV and Hep C prevention programs. So the picture is not pretty in terms of access to prevention programs where the evidence has been present for decades in terms of the effectiveness of both OST and NSP to prevent HIV and, to a less extent, hepatitis C in the region. What about the continuum of care? We focus firstly on HIV. In terms of the HIV continuum of care, the 1990-90, globally, the numbers are not looking good. In developed countries, in France, perhaps they're doing much better than others in comparison to the United States. France reports an 80% figure of those on ART. I have to point to the computer. Yeah, okay. Thank you, Professor Pan. And okay, that works. It's pointing here, but okay, never mind. In the United States, it's 34%. And needless to say, the percentage of people who use drugs who are virally suppressed is just simply woeful, ranging from 8% in Kyrgyzstan, and all these countries are countries with reasonably high problems with injecting drug use. Here in Thailand, it's reported that only 20% of people who inject drugs are on ART, and the level of undetectable viral load is only 9%. In Malaysia, we're not doing any better either. This is from a cohort that's being tested and followed through the Global Fund-funded case management program from the Malaysian AIDS Council. Although we managed to reach close to 5,000 people who inject drugs within the period of 1 year, only 50% underwent testing, HIV testing. Fortunately, the prevalence has dropped in Malaysia, but as you can see, only a quarter of those who were tested positive are on treatment. What about prevention? What about PrEP? We've heard a lot about PrEP this morning. The only PrEP study, as you know, famously, was conducted here in Thailand. And since then, there has never been any other PrEP studies around the world. And there are actually very few original studies on PrEP in injecting drug users. The literature that has followed are mostly from follow-ups of the original Bangkok tenofovir study. Following the announcement of the Bangkok tenofovir study, CDC has recommended that PrEP be also used in people who use drugs. But I think we all know that in terms of implementation, whether it's in in developed countries or in low and middle income countries, PrEP in people who use drugs certainly lag behind PrEP in MSM. The concern, of course, is the adherence, and here's some follow-up study in the Bangkok tenofovir study where adherence to daily PrEP amongst people who inject drugs was low overall, with of those who were still on PrEP, 47% had less than 10% adherence, but the 25% had very high adherence. And some of the factors that were associated with adherence include male sex, imprisonment, and injecting midazolam. Moving on to hepatitis C. Again, the American Liver Society and the IDSA, the Infectious Disease Society of America, recommends, this is from an update in 2017, regardless of treatment setting, recent and active injecting drug use should not be seen as an absolute contraindication to hep C therapy. There's strong evidence that people who inject drugs have demonstrated adherence to treatment and low rates of infection, depending on settings. And here's the 2018 guidelines, which states that annual hep C testing is recommended for those with no prior testing. More frequent testing if the level of risk is high, that we should be offering opt-out testing at substance use treatment centers and NSP programs with immediate RNA testing and linkage to care if positive, counseling, etc. And again, active or recent drug use is not a contraindication to hep C treatment. And at least annual testing for those who have achieved SVR or have spontaneously cleared HCV infection. And certainly there's not lack of evidence of the effectiveness of the DAAs in people who inject drugs. This is a systematic review and meta-analysis just recently published of the effectiveness of the DAAs for people who inject or use drugs for hepatitis C. And among individuals with recent drug use, the overall effectiveness is 87.7%, whereas amongst individuals who were receiving opiate substitution therapy, the conversion rate is much higher, is slightly higher, it's 90.7%. So certainly there is not lack of evidence that treatment of people who inject drugs with the DAAs for hepatitis C is effective. However, just like with the story of HIV, in terms of being left behind, there is no question that that people who inject drugs are not, by and large, globally, are not able to access the revolution that's taking place with Hep C treatment. So as you can see here, as it says here, DAAs only help you once you get here, but for most countries in Asia, the largest gap is up to 90 to 95% of HCV infected are unaware that they are infected. And this includes those who may have acquired Hep C through injecting drug use, but also through blood transfusion, etc. So the first order of call in our region in terms of hepatitis C is to raise awareness, particularly amongst people who inject drugs. And as with HIV, that cascade, the linkage to care will need to be improved in a major way if we are going to reach the kinds of SVR that we want to see. This is Van Gogh's painting, which leads me to the issue of mental illness. This, as I said at the beginning, when we take care of people who inject drugs, it's usually not a mono problem. There are a multitude of problems that need to be addressed, and this is from a very large cohort in the UK of 59 UK specialist centres that look after people who use drugs. With chronic Hep C infection, and they looked at more than 6,000 patients, close to 60% of whom acquired the Hep C through injecting drug use. And what they found was depression was common, certainly amongst people, previous injecting drug users. It's nearly half of them were having symptoms of depression. Those who are still using drugs, 68.1%, and amongst Hep C positive patients who are non-injecting drug users, around a quarter of them complain of depression. So mental illness and drug use is something that doesn't get a lot of attention, but certainly complicates care in a major way. These are some prevalence estimates that I could find in Australia. This is among substance use treatment clients. Anywhere between close to 50 to 100% have some form of mental disorder. Depression was found within 27 to 85%, and generalized anxiety disorder in 1 to 75%, whereas in the US, in a national survey on drug use and health, any form of mental illness, and certainly serious mental illness amongst people who use drugs is high. We found the same in Malaysia. No doubt this was in a cohort of prisoners that we engaged with in Kajang prison. 200 of whom were HIV positive and 200 were non-HIV positive. Overwhelmingly, the HIV positive patients were acquired the HIV through injecting drug use, because drug use is criminalized in Malaysia, so many are in prison. So as you can see there, the rates of psychiatric disorder is extremely high. Any form of psychiatric disorder is 44%. Psychotic disorder is 11%, and other forms of mental illness is extremely high in this cohort of HIV-positive prisoners and negative prisoners in Kajang prison. Unfortunately, the mental health services within the prison system in Malaysia remains a little wanting. Next, we move to chemsex, and you heard a little bit about it. You heard much about it from Fritz earlier this morning. You know, we haven't even managed to really, as a global community, we haven't really managed to deal with the traditional opiate disorders in terms of addressing the HIV, Hep C, and mental health concern. And now we really have to step up with, in inverted commas, new drugs, the ATS and other kinds of stimulants that you know, in fact, in many parts of Asia and Australia, and I think UK as well, has in many ways overtaken the heroin epidemic that we've lived with in the last few decades. So if we focus on this type of drug use among MSM, it's typically episodic. There's a wide variation by demographic groups. You have doctors, you have lawyers, you have others using these drugs. Polydrug use is typical, although injection has been low globally, but certainly it is not absent, and stimulant and club drug use are common. And this is a composite of recent studies of ATS use amongst MSM in Asia. As you can see, meth and crystal meth are some of the more common drugs that's being used around the region. And what it does, as you heard earlier, is that it is driving the HIV epidemic in the region. So they're more like in this study that my colleagues, Howie Lim, Thomas from here in Bangkok, and Rick Ortiz from Yale looked at, did a survey through an Asian Internet MSM sex survey. ATS use was significantly associated with having more sex partners, to have group sex, inconsistent condom use, to be HIV infected, and to have sexually transmitted infections compared to those who had negligible substance use. And you've seen this graph from Fritz, although his graph was prettier than mine. Okay, so what can we do in terms of managing ATS use in sexual settings among men who have sex with men? I think number one would be to address the stigma and discrimination that people who use drugs, as well as MSM in Malaysia and in the region, that that kind of is one of the risk factors for this drug use. So there is a need to, this was a qualitative study that, again, Howie and my colleagues did in a group of, I think it was a very in-depth study of about 20 MSM with who are using ATS. So there is a need to increase access to HIV prevention services such as PrEP and PEP, professional support, particularly mental health illness support, and substance use treatment for drug-using MSM in a more open and friendly environment, which is, of course, easier said than done in the setting of Malaysia. And finally, in terms of what interventions can we do, how do we address these huge gaps in prevention services, in treatment services for people who use drugs who are being left behind? I think one important principle is that the health needs for people who use drugs can be very different depending on the subgroup that you're dealing with, whether you're dealing with women who use drugs in Central Asia, or whether you're dealing with young men in young MSM in the UK, or prisoners, or those engaging in chemsex. In the traditional way, in terms of the HIV treatment cascade amongst people who inject drugs, we know that whether it's diagnosis, linkage to care, retention in care, receipt of ART, and adherence will differ based on local context and funding priorities. And I think this is where drug use is so criminalized, such as it is in my country, that we will need to look at interventions using technology to bring people into care and to link them into care much more than we're doing at the moment, rather than the traditional attendance at clinics and so forth. This is from Jamie Meyer from Yale, who did a summary of some of the evidence-based interventions that can be implemented based on at different levels of the HIV continuum of care, and which includes opt-out testing, on-site rapid testing, peer-driven interventions, community outreach, nothing that's really new or revolutionary, and certainly whatever applies to HIV certainly applies to Hep C. But as mentioned, all these interventions are very much easier said than done in a setting where much of the funding goes towards criminalization than towards healthcare of people who use drugs. I won't go into this because really, perhaps to just emphasize that integrated care, whether it's for HIV or Hep C, is paramount. And within it, drug use and psychiatrics. So this would be the Rolls-Royce of treatment for people who use drugs. You've got everything on site. But as mentioned, more likely than not, that site happens to be in prison. At least in Malaysia, where 60% of prisoners are in there for minor drug offences. I guess if you look on the bright side, this would be one place where you could initiate treatment and care, whether it's for HIV or Hep C. And it's worth emphasizing that whilst the health needs are huge for many who use drugs, especially if they've had time in prison, their health needs are pretty much secondary to other more pressing needs, like finding a house to live in once they leave prison, getting a job, getting connected to family, getting connected to society. So, going to the clinic to get themselves tested for HIV or to get their antiretroviral therapy is secondary to, getting back their lives. So, and their basic needs. So there are many more things that we need to consider when we're managing people who use drugs with HIV or Hep C. And so this is where I'd like to end, that the health needs of people who use drugs cannot be separated from the other psychosocial support that is needed. After all, if they still continue to live a chaotic life, the chances of them adhering to the HIV treatment or PrEP or Hep C treatment is going to be less likely. So equal attention needs to be paid towards all these other things, including underlying mental illness or mental illnesses that have come as a result of substance use when we manage people who use drugs. So I just want to end here by saying that the health needs for people who use drugs are enormous and varied, and the types of illnesses will depend on different contexts, and the types of intervention that we implement will be different depending on different contexts. Like I said, whether it's a woman in Iran or street drug users in Malaysia or MSM in the UK or Russians in prison. And by and large, people who use drugs are left behind in the prevention and treatment revolution that we're witnessing, whether it's for HIV or hepatitis C globally. And what really is required is a paradigm shift from criminalization of drug use to drug use being viewed as a health issue globally. Thank you very much.
So we do have a few minutes for questions, if anybody has any questions. While we're waiting, I have a quick question for you. So one thing we've seen in Bangkok in the last 2 years, which I'd never seen before, is injection of crystal methamphetamine, which seems more and more common among the MSM and transgender community. And I wonder if you've seen that in other countries in the region, and if people who inject crystal meth, are they somehow different than people who inject heroin, or do we need to address them differently in any way?
Yeah, I think we're also starting to see it in Malaysia, and going by first principles, they need to be offered the same kinds of prevention services, including clean needles and syringes. But of course, you don't have the methadone or buprenorphine equivalent, and that's where the much more research needs to be done.
We have a question over there.
Yeah. Hello. You said 60% of people got hepatitis C were intravenous drug users. So the other 40%, I mean, how did they contract it?
So in the past, from blood transfusion would be the most common mode of transmission, in addition to injecting drug use. But there is also a significant proportion where the source of infection is not known. I said 60% are in prison because of injecting drug use. But yes, a large component of people who get hepatitis C would be injecting drug use, previous blood transfusion, and a big unknown. Yeah.
Thank you, Professor Adeeba.